And next is a very interesting topic. The proper treatment of intra-articular calcaneus fracture, fix it or fill it, by Dr. Pongsathorn Chailerpongsa, Khon University. Please.
Good afternoon, everyone, and thank you for introducing me. Today, I'm going to share some insights about the proper treatment for intra-articular calcaneal fracture, fix or fuse. Let us start with a case example. She's 45 years old with a schizophrenia, had jumped from the second floor and was admitted for the delusion control for at the psychiatric ward. And the X-ray showed the joint depression type calcaneal fracture on her right heel. The CT scan showed a Sander type 4 with severe comminution of the calcaneus. In this case, I did a calcaneal OIF, but postoperative X-ray shows articular stepping after the surgery. CT scan show unreduced medial fragment. This is a case example of the severe comminution calcaneal fracture that even though we try to fix it so hard, and that the results may not like you wish. So the calcaneal fracture frequently causes by the falling from the height over 6 feet. It is one of the big concern in trauma problem because it has been reported worsen general health outcome than other orthopedic injuries. Calcaneal has a unique and complex articulation, and most intra-articular fracture involve posterior facet, which is the largest and function as a major part of weight bearing. For Sander classification, it is classified based on the number and the location of the articular fragment. It is widely used for determining both treatment and prognosis of the fracture. The goal of treatment is not only anatomical reduction of the joint, but also requiring restore the overall morphology of the calcaneus and getting the lowest rate of the complication. To obtain a good result, it may be require 35 or 50 cases for a surgical learning curve. Surgeons are able to perform OIF or the primary arthrodesis of the subtalar joint because there is no universal treatment to all calcaneal fracture. Since the 1990s, CT scan and fixation technique is developed. Lateral extensile approach is a gold standard for this post-articular calcaneal fracture. However, this technique has a high complication rate. At the last decades, synaptosile approach became popular and had a less complication. It is safe to perform OIF in early 72 hours after the surgery, after the injuries. Here are the retrospective studies from Professor Sander in 1993. There are 0% achievement of the anatomical reduction in type 4 Sander, and only 9% have a good to excellent result. And you can see 70% of the Sander type 4 patient has to have a late subtalar fusion after the first fixation. One interesting finding is that when you look at this paper, half of the Sander type C who are undergone the fusion later had no joint stepping after the first OIF. Moreover, although your surgical experience is increasing, for type 4 calcaneal fracture, fixation is still not improved. Let's see update evidence about the calcaneal OIF. This is a recent randomized control trials compare lateral extensile approach and synaptosile approach for the Sander type 2 and 3. This study show less complication, less subtalar osteoarthritis, and operative time in synaptosile approach. Moreover, it has a better functional and radiographic outcome than the lateral extensile approach. This study showed the same way with the recent meta-analysis. So synaptosile approach become a new gold standard for calcaneal OIF. However, in some cases, it is so difficult to maintain the reduction, like you are nailing a custard pie to the wall and it starts to welt again and again. like Professor McLaughlin has mentioned about the calcaneal OIF. So back into the history, the problem of calcaneal fracture is that anatomical reduction was impossible and the outcome would always be poor. So the first primary fusion was reported by the Dutch surgeon in 1911. First of all, we have to know that subtalar joint is an essential joint in foot and ankle. And progression of the post-traumatic arthritis is inevitable in most standard type 4 fracture due to the severity of articular damage. Primary arthrodesis can provide a reliable pain and functional outcome in severe cases like this. To achieve a good outcome in primary fusion, there are two parts of the procedure. First, you have to restore or reduce the calcaneal morphology, and then arthrodesis can be done. You can see a Bowler view affects the talo-calcaneal relation, which is important in ankle motion and Achilles function. Hugh-Wallace affects the biomechanics of the transverse tarsal joint. And if you don't correct the calcaneal width, patient may still have a subfibular pain. According to the systematic review in 2012, show the union rate of primary fusion is nearly 97% and AOFAS score is about 77. They also report a high rate of return to work after the primary fusion. Primary fusion can be done by the sanitary approach too. It also provides a good functional outcome and certifies pain score out over a 1 year follow-up. I summarize important steps how to do a primary fusion in calcaneal fracture. As I mentioned earlier, it is suggested to restore the calcaneal morphology first, like we do in OIF, before doing the arthrodesis. After that, subtalar joint was prepared by removing the cartilage by the culate or chisel. If the joint fragment is large enough, please try to fit it into the sternoculaar fragment by a small screw. In some cases, you may need a bone graft to fill your bone void after the fixation. In the final step, two standard cannulated screws were inserted to stabilize the fusion site. Here are the review of the evidence for both OIF and primary fusion. There are pros and cons in each techniques. Let us see together. In meta-analysis at 2021, compared to technique in just only standard 2 and 3, the results show better functional outcome in OIF group than the primary fusion group. But when you see in the standard type 4, there is only one randomized control trial to compare fusion and fixation. The results show no significant difference outcome between two groups. However, the author emphasized that the results may be occur due to the type 2 error. By the way, primary fusion can prevent late subtalar fusion and reduce losing the time from the work. And subsequent subtalar fusion is not as good as the primary fusion. Here is a systematic review. It showed the same result. It found that about 14% in OIF had a late subtalar fusion due to the pain after the surgery. So the important thing is more than the question which one is better. I think is this how can we choose? Which one is proper for fixation? Which one is proper for fusion? The principle is try to fix it because subtalar joint is essential joint in foot and ankle. In my opinion, standard type 2 and most of type 3 can be fixed very well. But in standard type 4, there is a big deal. Although you have a very good skill, your patient might not have a good result from your fixation. So primary fusion is a good choice for this kind of case. There are other situations that primary arthrodesis is to be considered, such as a lock fracture dislocation, extensive cartilage damage, and delayed treatment. For conclusion, OIF is still a good choice in a good surgeon who can achieve a reduction and avoid complication. In severe comminution or unreconstructible fracture, primary arthrodesis is recommended. Thank you so much.